The next part for the ASCO GU 2023 update is about the news in urothelial carcinoma. I would like to discuss three settings. One is the non-metastatic muscle invasive bladder cancer, then the muscle invasive but localized bladder cancer, and finally metastatic urothelial carcinoma. Starting with non-muscle invasive bladder cancer, you may remember the results of Keynote 057 with the use of pembrolizumab in CIS, non-muscle invasive disease for BCG unresponsive patients, showing certain benefit for pembrolizumab, although the benefit was debated. Now Andrea Necchi presented the results for the non-muscle invasive papillary disease setting, again using pembrolizumab intravenously as a single agent for up to 2 years in patients who were not responding to BCG anymore. And it could show a disease-free survival of 32% after 1 year. And so while I think that this shows that pembrolizumab has some activity in this setting, further research is needed before we can declare this as a standard of care. So I think this is interesting to be used in studies, but outside of trials, I don't really see the use of single agent checkpoint inhibitors in non-muscle invasive disease at this time point. Looking at muscle invasive bladder cancer and adjuvant treatment, there was an update for the Checkmate 274 trial. Checkmate 274 was using nivolumab for 1 year in patients who had residual PT2 or higher disease after neoadjuvant chemotherapy, or who had T3 or T4 disease if they did not receive neoadjuvant treatment. And Matt Goldsky presented the updated analysis with more than 3 years follow-up, and it clearly shows that the disease-free survival benefit is maintained in the whole group, and it's even greater in the PD-L1 positive group. However, and this is the big debate, still no data on overall survival benefit for this adjuvant treatment is available. And you may know that nivolumab in this setting is EMA approved for PD-L1 positive patients. I think this can be discussed in this disease setting, but we need to make sure that the patients fulfill the trial eligibility criteria. And certainly we're all waiting for the overall survival results. Finally, in the setting of metastatic urothelial carcinoma, there was the final analysis of the IMvigor130 study. IMvigor130 was a first-line trial looking into a standard chemo with platinum and gemcitabine compared to platinum gemcitabine plus the checkpoint inhibitor atezolizumab, or the use of atezolizumab as a monotherapy in PD-L1 positive patients. And the progression-free survival had been positive for the combination of chemo and atezolizumab, but OS was awaited, and now the overall survival results were presented, and unfortunately they were not statistically significant for adding atezolizumab to the chemotherapy. And therefore, this certainly is not an option, and actually atezolizumab has been voluntarily taken away from the US market, and the FDA approval has been well taken away by the company itself. When looking at single agent atezolizumab, there has always been this discussion: should we use single agent checkpoint inhibitor in metastatic urothelial carcinoma first line in PD-L1 positive patients? And here again, unfortunately, there is no OS benefit compared to platinum gemcitabine, also not in the cisplatin ineligible setting. It's not statistically significant, and actually in the first 6 months when using a checkpoint inhibitor monotherapy, there is an increased risk of death. And so clearly for patients who are able to to receive either cisplatin or carboplatin in the first-line setting. This is the standard of care, also according to the guidelines. Personally, I think single agent monotherapy with a checkpoint inhibitor can be indicated in patients who are not able to receive either cisplatin or carboplatin, so the so-called platinum ineligible patients. And there, the use can be seen also irrespective of the PD-L1 status. However, please note this is not approved in Switzerland, and therefore, if you do that, you need to make sure that you have coverage for it. And with this, these are the highlights for the urothelial carcinoma session. Thank you for your attention.